I'm Raajit Rampal. I'm associate member at Memorial Sloan Kettering Cancer Center, and I'm director of the MPN and Rare Hematologic Malignancies program, and director for the Center of Hematologic Malignancies. And my work, both in the lab and the clinic, focuses on understanding the biology of MPNs as well as investigating novel therapeutic agents. And I think this is a really exciting time in MPNs. There's a lot that has been delivered from the biological studies that have been done over the past decade. And, we're currently in a position where we have 4 FDA-approved JAK inhibitors, but also a lot of drugs that are in development, which I think is a profoundly exciting thing. But to kind of level set the conversation on myelofibrosis, you know, if we think about our primary goals for our patients are really to allow patients to live the best quality of life and the longest life possible. And I think that's, how I think about how we start the conversation about what we're trying to do with any therapy. Um, and along those lines, JAK inhibitors have made a difference for patients, but their major utility has been in reducing spleen size and improving constitutional symptoms. And more recently, we have drugs that seem to help us with improving anemia as well, which, as I'll talk about, is, I think, a very important endpoint to meet. But the one thing I think it's important to realize is that there continues to be a major unmet need in terms of having drugs that are truly disease modifying. Disease modifying to me means drugs that allow a patient to live a near normal lifespan with minimal issues arising from their disease. The JAK inhibitors that we have currently are listed on this slide, and they all target JAK2, but some of them also target JAK1, such as ruxolitinib and momelotinib. And ruxolitinib and fedratinib are really for patients with platelet counts of 50,000 and higher who have constitutional symptoms or symptomatic splenomegaly. And you see the toxicities to watch out for there. And one point here is that all JAK inhibitors can have cytopenias as a toxicity, namely anemia and thrombocytopenia. But we also have patients who have anemia and thrombocytopenia at baseline, and that's where some of the newer drugs come in. So pacritinib was approved really for patients with a platelet count of less than 50,000 in the first line, but it does actually seem to have an anemia benefit for patients as well. It can be used at any platelet count in the second line as well. And momelotinib was approved for patients with myelofibrosis and anemia, and has been studied in a number of trials, and certainly can improve anemia, improve spleen, and improve symptoms. So we do have a much better arsenal than we did even 5 years ago. As we treat patients, it's important to realize what are the landmarks that we're hitting. We want patients to feel better, right? And this is something you can assess with a symptom assessment tool or just by talking to the patient. But are there objective measures we need to think about? And one of those is spleen size. Spleen size reduction has been the primary endpoint of most clinical trials of newer agents, including JAK inhibitors. But does it actually mean anything clinically? And the answer is it does actually seem to correlate with overall survival. That is, having a spleen volume reduction seems to correlate with an improved survival in patients. How and why, I think, is a more nuanced question. Is this, an issue of making patients live longer because you're shrinking their spleen? Probably not. But is it a marker of disease responsiveness? I think that may be the answer. In most studies, 35% is the landmark that's used to say that that the drug has had efficacy. But the reality is even smaller spleen size reductions seem to correlate with survival. In this analysis, even getting above 10%, granted the numbers are relatively small. But this has also now been shown to be true with pacritinib, that if you get a 10% spleen volume reduction in cytopenic MF patients, they do seem to live longer than those who don't achieve that. So this is an important thing. And this is further established by something called the RR6 model, which has looked at some factors that seem to associate with patients doing worse over time on a JAK inhibitor, in this case, ruxolitinib. And one of those things is not achieving a spleen length reduction, not a volume, but a spleen length reduction by less than 30%. Those patients seem to do worse than patients who do achieve this. But the other factor is red cell transfusion independence. And early on, we do see anemia occur with JAK inhibitors that tends to get better after 3 months of time. And it doesn't seem like that anemia early on has an impact on survival, but anemia that persists, particularly transfusion-dependent anemia that persists after 6 months, really is associated with worsened outcomes. So, I think that, trying to address patients who are transfusion dependent is an important goal because it does associate with their overall outcome, number one. Number two, realizing that, most studies that have been done with JAK inhibitors, if you look at the proportion of patients who get a 35% spleen volume reduction, it's actually between 20 and I would say sort of 40%, meaning that the majority of patients aren't meeting that threshold. I don't know how many are meeting 10% and above, but the majority of patients aren't getting this threshold, meaning that there's work to be done to try to further the spleen size reduction. And finally, the thing we have to think about is that JAK inhibitors, in this case ruxolitinib, have a limited duration of efficacy. Over time, efficacy wanes, and there are well-described biochemical reasons for this. But this also represents an unmet need, right? That we do have patients who start out and they do well on ruxolitinib as an example, but over time efficacy wanes. And then what do you do? How do you help that patient? So we'll get into some data pertinent to that. But the data that I'm going to talk about now is an update from this year's ASH. And it addresses all of these kind of key limitations of our current therapy, right? The need to be able to treat patients after primary ruxolitinib or JAK inhibitor exposure, the need to improve on spleen size reduction, and the need, to improve anemia in our patients. So getting into this, first study I'll talk about was a real-world study called the JUMP study. This was an observational study of about 2,233 patients who had been treated with ruxolitinib for myelofibrosis in an expanded access fashion. And the analysis that was done here was to look at whether or not patients who had a baseline anemia that was defined here as a hemoglobin less than 10 versus those who didn't have a baseline anemia, if they did better or worse in terms of the primary endpoints of JAK inhibitors, which is really spleen size reduction and symptom response. And I think one important point here is that patients, who were not receiving anemia medication at enrollment, but started therapies like ESAs, were evaluated because this is an observational study. So what the bottom line of this data set is that, if you look at here in figure 1, and you look at the patients who had a hemoglobin of less than 10 in green versus those who had a hemoglobin of less than 12 in blue, you see that over time from week 12 to 24, there is a reduction in the patients with a spleen that was enlarged, meaning that you are seeing reductions both in patients who have a relative anemia and those who have a more preserved hemoglobin. And the same is true of a symptom response. But the important point here is that anemia was mitigated with other measures, showing that you can still derive important clinical benefits of patients who have a baseline anemia if you use adjunctive supportive measures like ESAs to support the hemoglobin through the initial period of time, especially when they are on ruxolitinib. So this is encouraging and tells us that, combination therapy with things like ESAs or danazols or even IMiDs, honestly, can still be a very viable strategy to treat patients with anemia and myelofibrosis. And here you just see the hemoglobin curves over time and also the transfusion requirements over time. You see that they do drop off over time after week 24, but this is something that has been known since the days of the COMFORT trials, where you do kind of get this U-shaped curve in terms of anemia that does get better after, a period of time. But supporting patients through that, to me, is kind of the critical message here. So speaking of the concept of how do you treat patients who've been on a JAK inhibitor and are no longer having a good response, what's the data for this? We've had data for a number of years with a number of agents. There was trials done with momelotinib in this setting, with pacritinib, with fedratinib as well. But this is the Freedom 2 trial that looked at fedratinib in this particular setting, but in a randomized fashion. And prior study that was done in this setting was the Jakarta 2 study that looked at single agent fedratinib after first-line ruxolitinib. Here you have a randomized study that is taking patients who are deemed resistant or intolerant to ruxolitinib. Now, there isn't necessarily a uniformly agreed upon definition of what resistance or intolerance is, and this is in the fine print down here. But patients who had been on ruxolitinib as little as 28 days, who developed a transfusion-dependent anemia, were allowed to be deemed as intolerant to ruxolitinib. Granted, that sort of counters what I've just shown you, which is that you can support patients through that period of time, and they can have a clinical benefit. So this is an area where there is definitely some gray area and room for disagreement. Let's put it that way. But at least what was done in this study was this took patients whose platelets were 50,000 and higher, who had persistent splenomegaly, who had been on ruxolitinib, and randomized them to get fedratinib or to receive best available therapy. And the endpoints here were the spleen volume reduction and the symptom reduction over time. And what the data was able to show is that compared to best available therapy, patients who got fedratinib in this setting had a significantly better spleen volume reduction, as well as a symptom burden reduction. And this included patients whose platelets were on the lower side of things. So patients who had a platelet count of 50,000 and higher versus those who had a more preserved platelet count, showing that you can certainly use fedratinib as a second-line drug in patients who have previously been exposed to ruxolitinib. And I think, that does back up the Jakarta 2 data. But again, granted, how you define resistance and tolerance in a clinical trial versus how you may define it in actual clinical practice, I think there is a bit of a gulf there. So next, coming back to the concept that ruxolitinib and other JAK inhibitors have developed, have given us a clear improvement in patient outcomes over time, but that there still remains an unmet need, has given rise to the idea of combinatorial therapy. That is to take a JAK inhibitor plus another novel agent that targets some other pathway that has been biologically validated in myelofibrosis, and use the drugs together to see if there's synergy. So one such concept has been bromodomain inhibition, and this comes from preclinical works that was done a number of years ago using JQ1, which is a test molecule, really, that showed, at least in mouse models, that there was a synergy between ruxolitinib and a BET inhibitor. And so this led to the MANIFEST studies, including MANIFEST 2, which is shown here, which was a randomized phase 3 trial that tested the combination of pelabresib, which is a BET inhibitor, plus ruxolitinib versus ruxolitinib alone, in patients who had myelofibrosis and previously had been untreated. And these are patients who had intermediate 1 or higher risk disease, had splenomegaly, and had symptoms. Patients here had a platelet count of over 100,000. And the endpoint here was spleen volume reduction, as well as a symptom reduction. And this was initially presented at ASH, not this past ASH, but 2 years ago. And the top line data from that study did show there was a clearly statistically significant difference in spleen volume reduction in favor of the combination, as well as a trend towards improvement in symptoms with the combination. At ASH this year was a week 48 update of this data. And this is really important that this study is being followed up carefully, because it's one thing to have a result at 6 months. It's another to say, is this a durable response? And what is shown here is the waterfall plot, whereby you see that the depth of spleen response continues to be superior with the combination therapy versus ruxolitinib alone. So the initial differences did persist, not necessarily the numerical difference, but the general difference that remains statistically significant. But also the durability. And I think this is a really important piece of data here, which shows that if you look at the durability of spleen response over time with a combination versus that with ruxolitinib, there is an emerging gap between the two arms, supporting the idea that it's not only depth of spleen response that seems to be better with the combination, but actually the durability. And if we go back to one of my initial slides, right, does this actually matter? Does this actually translate into patients doing well? The answer from previous studies seems to be yes, that those who do have this spleen response do better. Is that directly tested with this data? No. And I think we have to wait and see what progression-free survival and overall survival looks in, in these patients over time. But I think this is encouraging data. And here's just the symptom benefit, which continues to trend in favor of combination versus ruxolitinib, as well as hemoglobin over time, which tends to is trending higher in the combination arm versus single agent ruxolitinib. Again, all of these are parameters that are clinically important to us in managing these patients. Along keeping with this theme of BET inhibition, right? So this continues to be investigated with other drugs, and that I think should give some more credibility to the idea that this remains an important target in MPNs. There was another BET inhibitor presented, and in this study, patients who had previously been treated were given either monotherapy or combination therapy with a JAK inhibitor with this new BET inhibitor. And this was a safety study. So this is an early phase study. And, overall, you see the treatment emergent adverse events here, which includes cytopenias and GI side effects, all of which have been seen with other BET inhibitors, but none of this was dose limiting. But in terms of efficacy, we're showing both the monotherapy and the combination therapy arm. And, obviously this is an early phase trial. These are small numbers. And so without getting too nitty gritty into the numbers, on a high level, I think one can reasonably appreciate that these are patients who have been previously treated. And with monotherapy, you do see that there is a clear trend to reduction in the spleen size. And if you look at the symptom burden scores, the same thing is true, where the majority of patients, vast majority really, are having a reduction in their symptom burden over time. What about combination therapy? The same thing seems to be true, whereas the majority of the patients studied seem to be having a reduction in their spleen volume, but also in their symptom burden. I think this very much, dovetails with the data that we've seen with pelabresib, and I think again credentials BET inhibition is a valid therapeutic target in myelofibrosis, and so we'll see where this program goes from here. Another drug that's been being developed in combination with ruxolitinib is selinexor. Now, selinexor, of course, is approved for use in myeloma, but it has been investigated in myelofibrosis in early phase trials as a combination with ruxolitinib. And the top line data from this particular phase 2 study is presented here, showing that, in patients who were treated with a combination of selinexor at 40 milligrams daily plus ruxolitinib, if you look at the change in the spleen length, again, this is spleen length, not volume, you see the majority of patients did have a further decrease in their spleen size with the combination of selinexor and ruxolitinib, and this has been shown in previous iterations at ASH that the combination clearly does produce spleen size reductions, both spleen length, but also spleen volume, because there's previous data that's been presented with spleen volume reduction as well. And those numbers are favorable. They show, greater than 70 or 80% of patients achieving a spleen volume reduction. And as a context, right, historically, ruxolitinib as a monotherapy has delivered a spleen volume reduction of 35% in, 25 to 40% of patients, let's say. So clearly there does seem to be some evidence of combination. And here you see the symptom profile showing that, again, the majority of patients are having a marked reduction in their symptoms. With regards to safety, GI side effects were observed, but most of these are not high grade. Nonetheless, we do take them seriously. Same thing with anemia and thrombocytopenia as well, which we have known as side effects. There is now a phase 3 trial that is enrolling worldwide, which is randomizing patients who have been not previously treated to ruxolitinib monotherapy versus ruxolitinib and selinexor. And so that trial continues to accrue, and we'll await the readout of that to see if that changes the field. Another similar idea is imetelstat. Imetelstat, of course, is FDA approved now in MDS, and imetelstat has had a long development in multiple different hematologic malignancies that do include myelofibrosis. There have been several prior studies of imetelstat in the setting of myelofibrosis. But this particular trial is looking at a open label dose escalation phase 1b2 phase 1b trial of imetelstat in combination with ruxolitinib in patients with intermediate or high risk myelofibrosis. And again, this is a safety study. So you see here the adverse events that have been reported, most of which are certainly not high grade, but certainly cytopenias, which we know can occur with imetelstat from both myelofibrosis and MDS literature, as well as some other things like peripheral pain. But again, no dose-limiting toxicities identified here. If you look at responses, you see here the total symptom score changes over time. Granted, this is a dose escalation study, and of course, you're looking at different doses of imetelstat in combination with ruxolitinib. And the dose of ruxolitinib that was utilized here is variable, so it's not a fixed dose. So I think it makes it a little bit more difficult to interpret this data from an efficacy standpoint, but at least from a safety standpoint, there did not seem to be any major detrimental signs. And there is also an ongoing phase 3 study of imetelstat as a second line and beyond therapy in patients who have been on a JAK inhibitor. And this is a randomized trial that does not include a JAK inhibitor. So this is imetelstat versus best available therapy, which you see listed there. This study is looking at survival. This is really important, right? Because again, most of our studies have been looking at spleen volume reduction and symptom reduction, but this is a survival study. I think this will be a really interesting thing to see how it reads out. Granted, we'll have to put it into the context of our current therapies, which include a more expansive list of JAK inhibitors. But nonetheless, I'm sure this will yield interesting data. And speaking of phase 3 studies and randomization, in the second line and beyond, there is the Boreas study, which looked at navtemadlin, which is an MDM2 inhibitor. So MDM2 inhibitors have been credentialed preclinically. MDM2 regulates p53 expression, and the idea is that if you were to reduce MDM2, the amount of p53 expression will go up, and therefore more apoptosis can occur. And in fact, preclinical studies from Mount Sinai have shown that MDM2 levels are in fact increased in patients with myelofibrosis. So targeting MDM2 is in fact a very rational thing to do. So this study randomized patients to navtemadlin, which has been in development for some time, versus best available therapy. And these are patients who've been previously been treated for their myelofibrosis. The endpoint here was a spleen volume reduction by 35%. And you see here, just from the waterfall plot, again, it looks like the majority of patients did have some degree of spleen volume reduction. Only a minority of patients were able to achieve an SVR35. But again, is SVR35 the most important thing, or is it 10%, or what is the real threshold? That remains undefined, but I think it is clear and obvious that patients, the majority of patients did have a spleen size reduction, which was, less obvious with the best available therapy. And the same thing is true of symptom burden, where again, the majority of patients did have a reduction in their symptom burden as well. In terms of treatment emergent adverse events, GI side effects and cytopenias we're seeing, which we've known with MDM2 inhibitors. So this is certainly seems to be a class effect. So along those lines, this is also now in a phase 3 upfront trial. So this is a really interesting and innovative clinical trial design whereby untreated patients are treated with ruxolitinib monotherapy for a period of time, and then they are assessed for response. And for those who have a suboptimal response, they are then randomized to get the addition of the navtemadlin to ruxolitinib or just to stay on the ruxolitinib. I like this trial design because I think this is how these drugs will likely be used in clinical practice, right? Perhaps not as an upfront combination, but more like an add-on therapy in patients who are not having the response we want them to have. So I think this is more reminiscent of the likely uptake of any drug in real world clinical practice. This is going to be a large study because, as you can imagine, you have to have a certain percentage of patients who are suboptimal and then randomize them. So this is going to be, I think, one of the largest studies ever done in myelofibrosis. But this is up and occurring now. Now, kind of transitioning to anemia, one drug and study that emerged, I think, first at the EHA meeting in June was elritercept, which is designed to inhibit TGF-beta superfamily ligands, including activin A. And we've known that TGF-beta plays an important role in the pathogenesis of myelofibrosis. But this drug was being evaluated really in terms of the ability to improve anemia, but they also looked at a number of other variables here, including whether or not symptoms got better, whether or not the spleen got smaller. And, if we kind of look at the top line data, and just to backtrack, they studied elritercept as a single agent, but also in combination with ruxolitinib. If you look at the a reduction in transfusion burden over time, it's very clear that many patients were able to achieve a reduction in transfusion burden, including patients achieving 100% transfusion burden reduction. I would argue, honestly, and I'll talk about this a little bit later too, that even a 50% reduction is a meaningful thing, right? Even if you think about this on a practical level, right? A patient getting transfused every week, they're spending 4 to 6 hours a week in the transfusion suite, getting all of the extra iron. If you were to cut that in 50%, that's a meaningful thing, I think, for patients. But interestingly, and I think the thing that maybe perhaps caught people by surprise was that there were some spleen volume or spleen size reductions that were observed with the combination of the two, which is really interesting because, TGF beta has been targeted with monotherapies in myelofibrosis in early phase studies. And some modest spleen size changes have been observed, but you are seeing sort of more than one thing going on here, right? Anemia responses, spleen size is getting better. So this is very compelling and interesting data. Of course, it's early and we need to see more, but it is an interesting signal. What about other therapies that have not been thought of quite so much in the past? This was a really interesting study presented at ASH as well. And this is a phase 1b open label of add-on therapy with this drug, which is in fact a CXCR4 enriched non-HLA matched cryopreserved multidose Treg therapy. So you're giving regulatory T cells as the completely novel way to think about myelofibrosis treatment. And this is really based on the idea that there's dysregulated inflammatory signaling in MF, which we've known for quite some time. So the idea here is that the Tregs would be able to utilize that to their advantage. So this was a safety study mainly, and you see the adverse events related presented there, which really nothing so substantial, as well as the treatment discontinuation proportions listed. So at least it seems to be tolerable. I think that's the major takeaway. In terms of efficacy, again, I think it's always a little bit difficult to read too much into these small numbers, especially in a safety study. But no clear pattern with regards to spleen volume change. Some clear decrease in myeloproliferative symptom assessment form scores over time. So further study will be interesting. And then we come to another novel non-JAK inhibitor agent, which is a TP3654, now called nuvisertib. And this targets PIM1 kinase. Now, a number of groups, including our group, have studied PIM1 inhibition preclinically and found that it is, in fact, a robust clinical target in MPNs. And this is, one of the first trials to look at a selective PIM kinase inhibitor in patients with myelofibrosis. This is also a phase 1/2 study, and these are patients who have been previously treated, but were given monotherapy with this drug, TP3654. So there's no JAK inhibitor here. From a safety standpoint, you see here the adverse event profile, which includes GI toxicities, very low proportion of grade 3-4 events, mostly grade 1-2 events. And you see the dose escalation scheme as well. But importantly, no DLT was identified in this dose escalation schema. But as it pertains to activity, and what was shown at ASH was one of the dosing levels. So this doesn't represent all of the patients across all dosing levels. This is the 720 milligram BID dosing. You see that, in fact, you are getting spleen volume reductions in these patients. And again, this is in the setting of not having a JAK inhibitor, right? So as a single agent, this drug is able to reduce the spleen size in the majority of patients. But maybe more striking is the symptom response, right? I think we struggle with symptom response improvements beyond what we see with JAK inhibitors, but here clearly the majority of patients had a symptom reduction, but many of them had a very profound symptom reduction. Essentially 50% total symptom score reduction, which has been an endpoint for regulatory approval for drugs. You see this in quite a number of these patients. So I think this is impressive data that shows that this drug clearly has clinical activity as a single agent. In patients with myelofibrosis. Currently, it is being studied both as a single agent and in combination with JAK inhibitors. So we will hopefully learn more from those studies. And then finally, we come to DISC-0974, an anti-hemojuvelin antibody, which of course targets hepcidin regulation in myelofibrosis. And this is a drug that's being given to patients either as a single agent or in combination with JAK inhibitors. This is a phase 1b study that is initially just assessing adverse events, and you see the adverse event profile listed here on the slide in terms of the events observed. The way the trial was adjudicated for response is listed here on the left-hand side of the slide, where there was different criteria used for hemoglobin responses, including a minor response or a major response. And the trial included both transfusion-dependent and non-transfusion-dependent patients. And the bottom line is that in the patients who, in all patients essentially, what was observed is that a proportion of patients were able to become transfusion independent, and a proportion of patients were able to have a 50% reduction in their transfusion burden, which again, I think is a clinically important thing. And here you see a hemoglobin change over time, which I think is a very telling piece of data. So this trial, of course, continues to accrue and accumulate data, but I think some encouraging initial signs are seen here. So that brings me to the end of our slides, and I think some of the important highlights from ASH this year.